Welcome back. We're now going to have a session which is looking at our telecare responder services survey, which was conducted in January 2016. My name is Colin Anderson. I'm with the Joint Improvement Team, formerly Director of Social Work and Director of Communities and Wellbeing with Midlothian Council, and I've had an interest, especially in telecare, for a good number of years, and also currently chair the European Programme Boards for Smart Care and United for Health. So we can cover quite a range of issues in this session, depending on what your interests are and what the questions and answers are. I'm going to do a short contribution, and then we're going to have contributions from the members of the panel. You see before you there. Unfortunately, Tracy Harkins from Police Scotland has been called up to court duty, but I understand that Julie is going to cover off some of the joint work that we enjoy currently with Police Scotland. So we should have a full cover in this session. Okay, as I said, this survey was undertaken fairly recently, but it built on a survey which Doreen previously took with Tony O'Sullivan back in 2012. And I was reflecting last night on some of the findings of the 2012 survey, which covered about 15 local authority monitoring and response services. And it was saying that some had recently made considerable progress. And one of the councils that was identified, and I say this unashamedly, as having made progress between 2010 and 12 was my own council, Midlothian Council. And that really caused me to reflect on the critical success factors. And in terms of a responder service, it's a wee bit risky to start teasing out particular aspects of the service, because I'm fully committed to the idea that it is a whole systems approach that delivers the benefits that we need to see from telecare. And for example, our responder service, our call handling service, was initially handled by the same people who you would get if you phoned up to say that your pipes were burst in a council house. And what they looked for was an algorithm that would take you from Colin Anderson's daughter had phoned up to say she wasn't getting a response from her dad, and they wanted a series of questions you could go through. We developed a partnership with East Lothian Council, which, like my previous authority, Scottish Borders Council, where the call handlers had a care background. We saw a total improvement from that more flexible, responsive approach to call handling. As I said earlier, we also had telecare as a default position on our case management system, our core logic framework case management system. So when occupational therapists, social workers were actually assessing people's needs, they had to consider the installation of TEC services or telecare services as being part of that approach. In terms of case management, we also looked at, as you'll hear later, about key safes, and if there was not a family member available, could we look at voluntary responders? We also looked at, and this was fairly crucial, a joint rapid response team. So we had an out-of-hours response, which was a joint response between health and social care, and also mapped that onto a re-ablement service whereby we could re-enable people back through the re-ablement service rather than have a stock response of just increasing incrementally people's care packages. So that culminated in a reduction, for example, in Midlothian's ambulance service called out. And I remember Sue Scotland saying to me that when she had a look at that in a previous role, Midlothian had one of the lowest ambulance call-out rates in the country, and also impacted on unplanned hospital admissions. So in terms of that slide Margaret showed earlier, between telecare and home care packages and the home care only packages decreasing, I believe that in that, as Margaret says, it needs further analysis, but there's a real cost-benefit analysis from having telecare provision and having robust responder services. In summary, the 2012 survey had an overall picture of uneven service coverage, complex service structures, and stable performance rather than rapid progress towards rationalisation and improved response services within the context of a shared services agenda. And I think what you'll see overall is that the most recent survey has a very similar picture. And again, as Margaret was challenging us to think about how can we move this into a more kind of universal approach in terms of services as we go forward. I'm not going to go into the details of the responses that will be made available to you, but in summary, the total number of connections from the 24 responses was 112,220, and the majority of these were dispersed, Build being the largest provider with 24 connections, and I think Build is going to be present this afternoon to talk at the Responder Workstream workshop. We found there were real variations in the models of response. For example, although Orkney Health and Care had a 24-hour response, it was for the mainland only and not on the Isles. Stirling Council provided a 24/7 response, but again, because of the geographical area, they also used local volunteer key holders and responders to enhance their formal response service. So again, Scotland being Scotland, me being someone from Scottish Borders, having worked in Scottish Borders for 30 years, the bespoke is much better than the off-the-peg suit solutions, as it were. So that's something to bear in mind. In terms of funding, again, as you can see, there was a very small number of instances of relatively minor contributions provided by health, housing, and latterly the Change Fund, but that was transitional, obviously, rather than transformational, and was temporary in nature. And again, what we're hoping to see going forward in terms of strategic commissioning plans from the new Health and Social Care Partnership Boards, is in terms of funding, technology-enabled services will actually be part and parcel of that commissioning strategy, and in terms of the tactical approach, the resources necessary to invest in that will be reflected in future services. In terms of keyholder response, again, as I've talked about, the services were reporting fairly variable responses, and only something like a very small percentage of partnerships would the majority of key holders be required to be two family members without having recourse to actually try and find a volunteer in that area. And as you can see there, that equates to 3 partnerships. And our concern, obviously, moving forward is that councils or partnerships rather persist and in this approach in terms of key holders, then that would be a barrier to upscaling the service, and we need to think creatively about how we might respond to that. And in terms of the community responder service and transport, again, access to transport is a vital component of a dedicated response service to ensure that we can provide a prompt response within the current guidelines. And just a reminder, the TSA guidelines are within 45 minutes from the response service receiving the call. So again, services need to factor in transport costs when developing a dedicated responder service, and again, it's testimony to the whole system's approach. And in response to the community responder service, you can see there that, again, the percentages we've replaced by numbers, so it lets you have a clearer look. Again, you can see from this one in terms of the maintaining, repair, withdrawing community alarm and telecare equipment. So we would say that in terms of that whole joined up approach, it is necessary to make sure that the approach is consistent across these providers. The lifting equipment for service users' patients in their vehicles has been a fairly recent innovation and has had a significant impact. And the use of lifting cushions has grown rapidly. And we can now see 7 of the 21 responses to this question provided information on the number of times the lifting cushions were used per month, and this totaled 1,395. And over a 6-year period, this equates to 16,740. So again, if you multiply this by the cost for an ambulance call, it's a very, very simple but a very, very cost-effective solution, and it's had a huge impact on reducing numbers of ambulance calls and preventing hospital admissions. So in terms of winding this up, sorry, I jumped forward there, you can see that a joint working approach in relation to responder services is the key way forward. And as I talked about before, the joint working approach, for example, in response to build housing, where they do not have its own responder service, but link into local authority responders for East and Mid Lothian Council, Renfrewshire, Dundee, Stirling, Inverclyde, and a number of others. So again, what we're seeing is that the need locally to become integrated and to become more joined up in approaches. And hopefully the new Health and Social Care Partnership Board, and as I said before, the commissioning arrangements will promote this more integrated approach, especially in terms of locality planning, where I talked about these councils and partnership areas which are fairly dispersed and have townships where it's a fairly easy process to actually join up and coordinate, but out in the rural areas it's more challenging. And again, that's where locality-based responses and flexible responses are key. There will be an opportunity for further comments, questions and answers, but now what I'm going to do is to invite the participants to come up and give a quick presentation in terms of where they are at on responder services. And first, only because they're the only one with the slides, the well-organised, I'll ask Donna from Argyll and Bute to come and give her presentation.
Okay, it will be short and sweet. So, just a wee bit of background about Argyll and Bute for those of you that don't know. That's a wee map there showing you the area, and it's a very remote and rural area which includes over 20 inhabited islands, and our staff have to cover a huge geographical area. It can take you at least 3 hours, if not 4, to get from one end of our area to the other. And we currently provide services throughout the whole of Argyll and Bute. We've got in the region of about 1,100 basic telecare users and about 540 enhanced packages. We also use Just Checking and Canary to do monitoring of activities for daily living and for reassurance for family members. And we're increasingly being asked to use GPS devices such as Buddy and Pebble, although we have problems in Argyll and Bute with a very poor mobile network in some areas, so we're limited as to where we can use these devices in the area. Our current response arrangements are that each service user for telecare has to provide at least one person that can be a responder, and that would be a member of their family, a friend or a neighbour. We have an overnight response team who's Cargom, and they are contracted to provide us service from 11 o'clock at night till 7 in the morning, and they are operating within the main towns within Argyll and Bute, so still we don't have a service that covers the whole area. And if the service user requires Cargom service overnight, then we will provide them with a key safe as part of their package. If they're not able to provide anybody to respond during the day for telecare, then we are unable to offer them any service at all. So it prevents a large number of people having telecare. And we find it often in Argyll and Bute, most of their families have moved away and there's not many folk that they can ask to respond to their alarm. and they will often suggest a friend who already has telecare installed themselves, so it's not quite suitable for that. We have just recently, through the Integrated Care Fund, been lucky enough to get funded 5, which turns out overnight I've now found out is 4, locality-based telecare responder services. And this will cover the area now between the 7 in the morning and 11 o'clock at night, so that we will have full coverage for a responder service, although, again, it won't be right the way across Argyll and Bute. It is within the main towns at the moment. And obviously we're hoping that that will increase as time goes on. I'm not going to go through everything that's up there, but you can see it's going to enhance our responder services, and as will also allow a lot more people to have access to the telecare service than have previously. The service is also going to support people and their families to do a bit of falls prevention exercises to promote self-management and self-care. And it's initially going to start off with, it will support people who already have telecare, who maybe only have one responder, so they will be listed as a second responder. But as we go forward, anybody that gets referred to us that doesn't have a responder themselves, then they would be listed as on the responder team there. What else have I got? Finally, ultimately, obviously, this service will allow more people to have TEC installed in their homes, which in turn will help the Argyll and Bute Partnership achieve our TEC target. And I'm done.
Thank you, Donna. As I said, there will be opportunity for questions when we finish the contributions. Next on my list is Robin Lawrenson from the Scottish Ambulance Service, for whom the bell tolls. If you'd like to come up here so that... No, I see, I just like to keep people on their toes.
Hi, thanks. I don't have a presentation as such prepared. As far as the ambulance service is concerned, this is a very difficult area for us. When the public call 999, they know one thing is going to happen. A big red, white and blue Nina is going to come out and end up outside their house. Here's the news for today. We can't. In fact, we never could. We cannot do that. We do not have enough ambulances. We have 700 to cover the whole of Scotland 24/7. Last night in Edinburgh City, how many ambulances were on duty? Have a guess? 2. 2. They have to get from one side of Edinburgh to the other, according to our government standards for an immediate life-threatening call, in 8 minutes. A call went out from this area today to Kirkintilloch because it was the nearest resource. We tried Cambuslang to Kirkintilloch in 8 minutes. We can't do it. And in fact, we know we don't need to, because when that call comes, and let's call it, say it's a community alarm, what do they actually need? Well, the first difficulty is that we don't know. This could be somebody with an immediately life-threatening illness, or it could be somebody who's fallen off a chair. We do not know. So what we do is provide a range of services and try to match that service to the need. To do that, usually we need to talk to somebody. If nobody has talked to the person who has the need, it's very difficult for us to respond. With a community alarm, therein lies a difficulty. If we can get somebody to talk to us who has spoken to the patient, we can then interrogate. So we can't send an ambulance. What we can do is find some way of talking to that patient or to somebody else. Because we know we can't send an ambulance to everything, we don't send an ambulance to everything. What we do is call somebody back and have a conversation. Then we can decide what to send. We may not send anything at all. We have algorithms and computers and all sorts of different things and some very nice and clever people who can match the need to the demand. Because Everybody thinks they know what a paramedic is good at. A paramedic is not good at making diagnoses and discharging patients, because that's what a doctor goes to 4 or 5 years to medical school to learn to do, to safely discharge patients. A paramedic hasn't done that and is not good at that. What they're good at is saving your life. That's what they're trained to do. The rest of it all gets a bit woolly, and then they need to speak to somebody else and say, I've looked at this patient, I think it's ABC, can you tell me? And that other person may say, well, I don't know either because I'm not there. So maybe the paramedic wasn't the right person to be there in the first place. So what we're trying to do is get these systems to speak to our systems, and the Scottish Ambulance Service is the most technologically enabled in the UK by far, so that we can arrange to have the correct response go to the patient with the need. That is almost, that's 96% of all our calls are not immediately life-threatening. So we're sending somebody with a big machine to does all sorts of fantastic things to somebody who doesn't need it. And we're not getting to the people who need that service because the majority of our staff are going to calls that are really unnecessary for their skill level. That's the problem that we have to solve. And the biggest difficulty behind that is that in a Scottish ambulance service, when you've just seen the list up there that everybody has a different system, we have 3 control rooms, so a person in the control room needs to know which side of a border you are to know what responders do you have and whether they're 24/7. Right. So there are difficulties. Our hope, because we have some fantastic systems in ambulances now, is that we can start to break down the barriers between all the different health boards, councils and responders and start to get the technology to actually help us. We've just put 1,400 of the latest tablets in all our ambulances. And the difficulty, and somebody said earlier, is that this hole in the wall, which we take for granted, is terrific. But we're not 240 volts and Wi-Fi. We're 12 volts and a glorified bread van and the Vodafone system. That's all we have. There isn't anything else. So we've made some fantastic things to cope with that and compensate. But when you're in your car and somebody calls you and you say, I'll sort this out when I get back home, well, of course, because the Vodafone network isn't actually very good. That's what we have to live with. So whatever system we come up with has to be mobile. Very, very difficult in Scotland. And we now have 4G, 3G, 2G accumulators and satellites and all that sort of things in all our vehicles to make that possible. So we will solve any of the technological difficulties that we encounter. The only one we can't solve is who's having the ideas to provide the solutions. And when we try to break down the walls and partnerships with people, usually we get a response that says, that's not part of our 2-year IT plan, so it's not a priority for us. The things that work with us, we call agenda coincidences. When somebody else so happens to want the same things we want, there's a chance that it'll work. Otherwise, it's not their priority, they won't do it. These are the things we have to solve. And in my mind, the issues are within our clinicians, which I include myself one, not telling the IT people and the telecare and the telehealth people what they want. To say, this is what we need for patients, solve it. That's the biggest issue that we have. Thank you.
Thank you, Robin. That was a useful reminder about the importance of technology, algorithms, but mainly people. And it goes back to what I was talking about, the call handling and how, and I think in future, maybe when we do a deeper dive on responder services, we need to look at the background training, etc., of call handlers so they can harvest the kind of information that's required to make the triage decisions that Scottish Ambulance Service needs to make, and then it's fed into technology. But people are as important, if not more important, than technology, is the message from there. Staying with emergency services, I'll now ask Alan Doyle from Scottish Fire and Rescue Service to come and make his contribution.
Thank you. And can I say welcome to the Scottish Fire and Rescue Service headquarters. It became our headquarters yesterday. So this is the new home of us. I was asked to talk about the responses. Colleague there from the ambulance services put it very clearly. Responding is a difficult situation. Fortunately, we're going through a process of being 8 fire services going to 1 fire service, which also includes our control rooms. 2 have already closed down and we're merging across the others. From the public's point of view, they're not going to see any difference. They'll still get the response. To the kind of homes that we're looking to respond to, that your services are going to be installed in, you will always get a response, and you'll get a response to 2 fire appliances as a minimum, because it's a sleeping risk. Now, when I say 2 appliances, colleagues from Argyll and Bute, where I used to work, we've got 1 hold-time station in Helensburgh and 1 in Oban. In between that, and on the islands, we've got a mixture of what we called volunteers, and we've got retained firefighters who have a pager. So it might take them 5 minutes to get into the station, find out where they're going, and then respond. So the delay in rural areas isn't going to be as rapid as it is in the built-up areas. But we will mobilise appliances, and it's a bit like moving people around, playing Monopoly, moving them around the board. If one appliance is out, all the floods we've had recently in certain areas, they're obviously busy responding to that, so we have to bring other appliances into that area, but we will always respond. One of the issues that we face when we're dealing with technology and alarm systems are the false alarms. Within the Scottish Service, over the last year, we've had 58% of our calls turn out to be false alarms, which is 49,000 visits, trips. Now, the problem there is safety critical. Once an appliance is on the road under blue light conditions, then both the public and our crews are at risk. The last time under the old service where I worked in Strathclyde, in the last year there was over 100 accidents involving appliances. So there is that risk going to an incident. So we really want systems to be smart. We do have people in the control rooms who will ask if they get a human being on the end of the line, is there a fire and what's the fire, etc., and try and define what's happening. But if it's an auto dialer or just a call coming in, then we'll mobilise 2 appliances. Now, more and more people in new housing, there's built-in systems where the fire alarm and the burglar alarm and a response goes out, and we're responding to more and more of those. The telecare system is growing across the country, and that's something we want because we've always wanted that early warning system to be in people's homes. So it might be, I'm not going to decry it because we need it. We need to know where the incidents are happening. Another thing the fire service has been doing quite successfully, and we're up at about 68,000 visits a year, are home fire safety visits, but they're battery operated alarms that go in, so that they don't tell anybody. And that's a stopgap until somebody gets a hardwired system, which will operate if they're in difficulty. And we will rely on those calls coming in, but it's making sure that those calls are accurate calls. And that's the downside to it. Okay, thank you.
Thank you, Alan. In terms of responder, it just reminded me that I was driving up the A7 from the Scottish borders last week, and I knew the borders were in trouble as I drove up the A7 because 3 fire appliances were on the way down, and the last one was towing a boat. So I thought, it's raining. Okay, we'll now move on to Liz Watt from Aberdeen. Thanks, Liz.
Thank you. The response service in Aberdeen that we have just now has really kind of evolved through necessity. It hasn't been planned in any way, it's just happened over the years. We still ask service users to provide names of contacts that can respond if an alert is raised. But we're finding more and more that a lot of people do not have these contacts, do not have family members, and most of their neighbours are maybe older than they are. So we have managed to provide a response for them during the day from 8 till 6, Monday to Friday. The community alarm assistants will provide that response. And out of hours, our mobile wardens will cover those people who do not have a nominated contact. So what we have found that the mobile wardens are also covering the sheltered housing blocks. So overnight they're providing a response to over 3,000 people. And during the day, our community alarm assistants are at present covering 279 people in Aberdeen. The problems with this is that it's not a dedicated service. It's taken people away from the job they're there and have been employed to do. And with the shift in balance of care, more people living at home have much more complex needs. So given this complexity, the question that we have to ask is family members and our staff the best response service for them? Are they getting the correct support? And should this be a more professional, dedicated service that's in place? Our community alarm assistants are there to install alarms and review the service that we provide. They are not trained responders. They basically are acting like a family member would. They're going in to assess the situation. And if someone requires personal care, then they then have to go and call for that later. So this is delaying the correct response that the person requires. We have found that call-outs have risen quite considerably, just even last year. During the day, it's not so bad. We had 177 call-outs in the year for our community alarm staff. But the mobile wardens in the first half of 2015 had 2,738 call-outs. But in the second half of last year, that rose by 25%. So we're seeing a huge increase in the number of call-outs that staff are having to deal with. There has been a review of sheltered housing in Aberdeen, and this has been undertaken since 2011. There's a redistribution of amenity, sheltered and very sheltered housing, and we've now created a new category called Amenity Plus. So people within Amenity Plus have the option to have a community alarm or use family or friends as their response. But not having a dedicated responder service is having an impact on this housing situation. So we certainly are looking in Aberdeen to review that. The Integration Board has set up a TEC work stream, and one of the first topics that it has been exploring is a responder service for Aberdeen. So, the problems with the model that we have and are finding is that we have no flexibility. We don't have enough dedicated responder staff to deal with the situations in Aberdeen, and that fewer people are able to provide contacts. So we really need to make this an urgent situation that we look to developing a dedicated responder service for the city. We're finding that the pressure that's being put on existing services, our mobile wardens and our community alarm staff, is unacceptable, and that an appropriate response is really being delayed because we don't have that dedicated responder service. So it's certainly something that we're looking to take forward within Aberdeen.
Thank you, Liz. Some themes beginning to trend through these presentations. And finally, Julie from Renfrewshire, and a wee bit tag on behalf of Police Scotland as well. So there you go.
Hi there. I'll give you a wee bit of an overview of the service that we provide in Renfrewshire Health and Social Care Partnership. We currently have 3,600 service users across Renfrewshire, and we have a dedicated responder service made up of 44 responders, 4 team leaders and 2 telecare technicians. The telecare technicians have been currently funded through what was the Change Fund and now the Integration Fund, and they primarily install all the added peripherals, your telecares, your bed sensors, door contacts, linked smokes, and get people out of hospital much quicker than they would normally have done. They work a 4-on, 4-off rota, so there are 2 technicians, they're on a longer day, and so they're right through the weekend. So we can get someone out of hospital much quicker and get the equipment installed. With regard to the responder service, we are the response 365 days a year, 24 hours a day. We have a dedicated night shift staff as well. At referral and installation, we can either take 2 key holders who live locally within Renfrewshire, or we can install key safes at the door, or we can hold keys for the person. It's very, very rare, it's the exception, if a family member is to be the response, and that could maybe just be because they want to be, and we can make it bespoke, but the majority, 99.9%, take on the responder service as the response. We are TSA accredited, so we will aim to be there within 45 minutes. Renfrewshire borders about 4 authorities I can think of: Glasgow, East Wren, North Ayrshire and Inverclyde. So we're a fairly compact authority, but you can get from one end to the other within 45 minutes. But it's a very, very busy service. On average, on a month, we get about 10,000 calls, which kind of compares quite considerably to my colleagues in other local authorities that I've just described. And again, that's quite a busy service that we have. Within that, we have more recently through the TEC Fund and 4 additional posts, which are going to be primarily involved in installing equipment to get your basic units to get people out of hospital much quicker. The wee bit that I was going to say about Inspector Harkins was due to come today, which was called to court. We've built up a relationship locally with our local police service. Within Renfrewshire, we have door contacts, just like anyone else, or we assume that all other local authorities do that too, and we are the response. We activate the door contacts on a nightly basis and we deactivate them in the morning. The reason that we do that is to ensure that the person's actually in the house when we're activating the door contacts, so that, and we usually, the responder will see that they're there, they're safe, they're maybe in their night clothes or they're in day clothes, and we'll record all that. Previously, we responded to the call via our control centre. We arrived on site, we checked the person's either at home or they're not at home. If they're at home, obviously they're back in, they're safe and sound before we've got there, and we reactivate the door contacts. If they're not at home, previously we would have looked for the person for 15-20 minutes and then alerted police and family. However, since last year we've been working very, very closely with Police Scotland, and they now have all our information. We hold a photograph. When a new referral comes on, a photograph's taken of the person. We give a description of their height, their build, their eyes, their hair, and a pen picture of where they're likely to go when they leave their home. So for many people, they're heading off to the school at 3 in the morning to pick up their kids, or they're going to their workplace, something like that. So we've got a picture, an idea of where they might be. So now all of that information, at the point that we have the information at the start of the referral and the installation process, is passed to Police Scotland, and they're holding that locally. so that when the call comes through and we ascertain that the person's not in the house, we will look for them, but we will also contact the police at that time. They've got all the pictures will come up in their palm helds and all the description, and they will also search for the person. So it might seem like a small amount of time, cutting out 15 to 20 minutes, but that, as you know, that can be life-saving. And in the weathers that we've been having, people are out wearing their night clothes, there's lots of flooding. No one wants anyone missing, no one wants a death. Certainly, once the police start activating helicopters and all that going out, their resources, their costs go up. So if we're all working closer together sooner, then if we can save one life, that's crucial. So that's the kind of work that we've been doing locally with Police Scotland. Going back to our general response, we respond to all calls. We respond to calls for falls, personal care, emergency toileting. No responses, general reassurance. Hopefully the control centre will deal with reassurance calls and we might not have to be deployed. They'll be part of our figures for our 10,000 calls per month. But by and large we respond to a fair number of calls. We have more vehicles, more responders on duty during the day between 6 in the morning and 10:30 at night than the ambulance service have vehicles in our area, or have what do you call them? Ambulances? They're not appliances. Or if it's a jeep, if it's a with one person in it, whoever's out, we've got more responders on at any one time. We carry the lifting cushions like most of you will do, and we can get people out of difficult or tricky fall situations that we don't have to call on an ambulance to help us to do that. So we believe that we are preventing to the unscheduled admissions into hospital and keep people at home for much longer. Okay.
Not quite yet. Sorry, eager anticipation I saw there. People saw the lunch come up and the Pavlovian responses kicked in. But we will be taking lunch at 1 p.m, so we've got 15 minutes for questions. Again, I guess we saved the most comprehensive and integrated for last. So now is the opportunity for you to ask questions. I've got a general question which I'm going to be pursuing with individuals, not necessarily for discussion just now, and that's these services that are funded through Change Fund and now Integrated Care Fund in terms of exit strategy, which means that they've been evaluated in terms of cost effectiveness, so that when it's mainstream funding, you will have a case that will stand up. So I'll be quite interested to do some follow-ups with partnerships who have got services in there under Integrated Care Fund, and looking at how, as I said, they're being evaluated in terms of an exit strategy and hopefully to integrate within core funding. So I've been tasked with listening to your question, repeating your question, and then addressing it to the appropriate person. And to do that, I'm using this magic wand, which now has, in the best technology ways, it ran out of batteries, but it's now...
We've been working quite closely with Scottish Ambulance Service to look at a better way of supporting responses from yourself. Am I right in thinking, the way you spoke today, it'd be better not waiting until the paramedic's in the house and then directing it to an alternative support, but actually getting into your call centre area and giving you a menu of supports that can be accessed from there? You know, it sounds like we're working with, we're working at the place where the ambulance service has been called out and they're saying they don't need us, but they need somebody. Can you help us? But I think what you're saying today is, no, let's get into the call centre and actually do it there rather than waiting until the ambulance has been called out.
Thank you. I think what the problem that we have is that we know very often that we're not the right service. By and large, there isn't another one. So we pop a patient along to an A&E department and they're in the news the next day, and we all know how that story goes. What we really need is something called a directory of services. So if I'm in an Ayrshire village, I can pop along and say, this is available in my area, this is what it responds to, this is the contact details, and this is the times it's available. I can then make a phone call from a vehicle, and we can have a professional-to-professional discussion about the patient. As long as somebody gets to see and speak to the patient, I think our services can work very well together. It's when that doesn't happen that's a difficulty. And this thing about rushing people off to A&E departments has to stop.
Yeah, Anne, I think I'm not going to run upstairs with this, so I'll relay your question. Anne Steele, East Renfrewshire.
And it's a question for Alan.
Alan.
We have a very close working partnership with our colleagues in the Scottish Fire Service, and all our healthcare service users receive a standard like smoke detection. Now, part of that partnership was around reciprocal training, and we have our own in-house call monitoring centre, and the Scottish Fire Service trained our call handlers in how to appropriately call challenge, which has really significantly reduced the amount of false alarm activations then being escalated to the fire service. So my question to Alan was, what is the potential for that to be built into the Scottish Fire Services strategy to provide that training nationally to all the call handling centres?
Okay, so that's about training for call handlers.
Okay, I'm not going to make any promises. No, it's quite a logical step to have made, and I know BEALD and other organisations have also asked for that. So it's something that is being looked at, because it certainly will help us and help you with dealing with the false alarms. Also, I see the calls that are coming in as a near miss as well, because quite often it's an individual who, yes, they keep burning the toast, let's make it a minor incident, but is that distraction, is the early onset dementia affecting them and their rationale behind what they do, so that can have consequences in the future. Does that help?
Okay, any other? Just one here, yeah.
Helen Hunter from Quarriers.
Helen Hunter from Quarriers.
It would seem logical that with the expansion of telecare that there has to be a significant expansion of responder services. If you were thinking yourself into the future to a super duper responder service, could each member of the panel prioritise a one must for inclusion in that service?
So this is in terms of responder service, one must for inclusion. I'll start at this end.
I'm going to be quite flippant here, because if there is a responder service that works in Argyll and Bute, they're going to need a helicopter, because it is just so vast that one service will not do Argyll and Bute. It needs to be very bespoke in different areas, islands and the mainland.
Probably for us to do away with the paper that we use, and so that when the responders are out and they respond, it would be a pen, and like when the joiner from the council comes to do a job in your house or whatever, he does his, and that's linked through to somewhere within, and that's what I would like our responders to get on to be more digital themselves.
From a personal point of view, I think it has to be the training of your responders, and I think it's working with, like the ambulance service and the fire service, to ensure that these responders have the appropriate training to deal with the situations they're coming up against.
As well as our 650,000 emergencies every year, we also move around 1.5 million patients around Scotland. A lot of these people are not in the first flush of youth. And without any question now, there will be somebody in their 80s or 90s being moved from a village, coming into Glasgow to see a 26-year-old doctor, which I think is very unfair. What I would like to see, and the technology to do this is perfectly fine. If you're in a village on the edge of Loch Fyne, the community centre should have a video conferencing network where you can patch through to the doctor, who speaks to you, looks at you and says, I'll see you in 3 months, instead of being driven across the hills and valleys into Glasgow and then having to wait to go back again. That would be the biggest asset for me.
Thank you. Now I've had time to think. A lot of the systems that are in existence need to be upgraded, because once part of the system is in use, it blocks another part, and we've had instances where the fire alarm was actuated, but everyone thought the call was coming through, but it wasn't coming through. So we need to upgrade some of the existing hardware.
Okay, I'm going to wind up on that note and thank our contributors very much. And just to leave you with another thought in terms of responder services, because as I said in the introduction, one of the things that I do, I chair the European Programme Board for Smart Care. And when we were thinking about how could we take advantage of the smart care approach, we suddenly realised that across the Lanarkshires, the Renfrewshires and the Ayrshires, we literally had tens of thousands of people who had very simple technology, i.e. a community alarm. But when we looked at what would happen if Mr. Anderson fell down last night, not through drinking, because I've just finished dry January, I hasten to add, typically there would be a call into the community alarm handling service, which would be, are you fit enough to get up? And if you are, okay, we'll contact your relative. If you're on the ground and can't move, the default position would be probably contact the ambulance service. But what we looked at, and Alan kind of referred to this in terms of dementia responses, but what we looked at that, okay, what might be a more appropriate response? So it would be to use falls as an index condition and to get the local falls coordinator out and to look at things like blood pressure, medication, slip trip risks, etc., and then to look at, if there are repeat calls in, to look at the pathways approach, both in terms of a pathway for people who had the potential to fall, people right up to people who had fallen and had been then rehabbed back through hospital admission. So in terms of a responder service, that was something which was responding, if you like, to very simple, basic technology, but it was a paradigm shift in terms of an algorithmic approach to that response. It was somebody who was listening, who was triaging, and who was designing a different response to these calls, and indeed was aggregating calls. So instead of them being dealt with as separate dislocated incidents, it was being joined up and the aggregate impact was being looked at. So I'll leave you with that thought where I come into this, that it's not just about the different component parts of the responder services, it is that integrated whole system approach. And as it says in the plate, it's now lunch break time. Enjoy.